Thank you for your kind introduction. Today I'm going to tell you about the preoperative assessment of liver function for safe hepatectomies, a general review of a liver function test. I'm going to start with the introduction, and I'm going to say a little bit about traditional liver function test, and the main topic will be about recent trend of liver function test, and I'm going to finish this talk by saying future perspectives and conclusions. Liver failure, as you know, is the major cause of mortality and morbidity after partial hepatic resection, and that's because of insufficient functional remnant liver mass. Post-resectional liver function is largely dependent on the quantity and quality of remnant liver. So assessment of liver function is therefore very important for workup the patient who is going to have hepatic resection. Usually the computed tomography volumetry is currently very important standard method to detect the liver volume, and several liver function tests, including passive liver function test and quantitative liver function test and molecular nuclear imaging techniques have been evolved and developed in the last decade and still ongoing. This presentation primarily focused on the general concept of this measurement of hepatic function, and then additionally the application of quantitative liver function test is discussed later. This is the data of post-hepatectomy complications. As you can see, the 30-day mortality is around to 5 to 10. Post-hepatic liver failure is around, sometimes we can get 30% of post-operative mortality. This is data a little bit simple, make it simple. If we have a normal liver, the complication rate is a little bit lower than that, and post-operative mortality around to 5%. When we have a cirrhotic liver, it's difficult to get the good result. Liver failure is around to 10, and the mortality rate is almost 10%. So that's because the liver has liver function. Liver has various functions. For example, it has to transfer compounds, and it has to make lots of proteins. So if we do the liver resection, lots of growth factors and cytokines secreted from the cells, and it can make a liver regeneration very fast. But lots of things, for example, sepsis and small for size remnant and ischemia reabsorption injury, this kind of event can happen. So many bad materials and cytokines, and finally it can cause hepatocyte apoptosis and necrosis. It is regarded as hepatic failure, and then this kind of hepatic failure usually high bilirubin level and prolongation of postmortem time and encephalopathy and ascites. And then this kind of a liver failure can be graded as an international society meeting, a grade A, B, C, and this kind of liver failure prevented by massive volume manipulation and preservation, and sometimes hepatoprotection. But still, it's very difficult for us to get that, this kind of a liver function protection. Sometimes we have to meet this kind of severe post-hepatic liver failure. And this kind of failure can be managed by step-by-step management. Sometimes it's very hard for us to get it. So I think the most important thing is to get the preoperative risk assessment with clinical assessment of the patient and various liver function tests. So for the first time, we have to think about the risk factor of the patient, the older age, and then several hepatitis. And the preoperative chemotherapy can be a very we have to think about it very carefully. And then surgery-related and patient-related and miscellaneous risk factors, we have to think about it together. Usually, if we get the 20% of normal liver after the surgery, it is good to have as a normal function. In the steatotic liver, 30%. And in cirrhotic liver, if you get over 40%, it is safer for us to get a good hepatic function. It is impossible to get this good volume. We have to do the polar variant embolization before the surgery. So I would like to move on to the next traditional liver function test. Preoperative liver failure determinant is very important. We'd like to get the assessment of remnant liver volume. The test should be capable of recognizing liver loss, and the test should discriminate cirrhotic and normal liver, and the test predict post-operative liver risk. So usually the liver function test can be conventional and scoring system and quality test altogether. And conventional test, the test should be every single test is important for the liver function test. We have to think of every single test as important. Another is a scoring system. Child classification, as you know, is a very old and very good and widely used scoring system. So everyone knows about these 5 factors. It's important for us to understand. And another score system is MELD score. Creatinine and bilirubin and INR is important parameter of this score. And then MELD NA is we can add sodium for this MELD score. MELD score usually widely used in the transplantation field, as you know. The quantitative test, usually the clearance, retention test, and redox chemistry and volumetry and scintigraphy will be the good quality assessment of hepatic function. The qualitative test usually can be divided into 2 parts: non-isotope methodology and isotope methodology. Non-isotope, the indocyanine green will be the best, and an isotope methodology, usually technetium-99, mebrafenine, scintigraphy will be one of the most important scintigraphy we are going to use. Quantitative non-isotope method is indocyanine green. I think the compound can be taken up to the liver, and this compound can be usually metabolized in the liver. We can detect the trace amount or metabolite from the blood, and it can be used as a qualitative method. In the cyan green, as you know, that below 10 is a limit, and above 10 is kind of a deranged liver function. So it's a good marker for the liver function of the patient. Tons of papers have been published about this indocyanine green 15, and I think indocyanine green is worldwide nowadays is a good functional test of the liver. Next is about volume measurement. As you know, volume measurement is very important for transplantation and post-op embolization and post-resection liver failure. So if we do the CT scan or MRI scan, we can get resected liver volume and total liver volume and remnant liver volume all together after the one-shot CT scan. So many papers have been published, and then this kind of CT volumetry technique is evolving and now ongoing project. Recent trend of liver function test is quantitative isotope method. It's not a brand new, but nowadays it can predict functional liver volume after surgery or transplantation. So this is the slide that after portal vein embolization, left lobe is hypertrophed, and this left lobe show high intensity. That means this left lobe is high functioning. As we can calculate liver volume and the liver function together with this scintigraphy. Tons of papers have been published, and they are well correlated with indocyanine green and other volumetry study. New imaging techniques. So we are usually doing manual volumetry nowadays, but nowadays so many brand new techniques, for example, 3D image and the blood flea volumetry has evolved. And then when it comes to hepatic steatosis, liver spleen ratio or liver attenuation index or MR spectroscopy will be the other option to identify the hepatic steatosis in the liver before resection. So those papers, they talk about MRI for good standard for qualifying hepatic steatosis. The last thing I would like to say is serum markers. So nowadays we're trying to find the serum markers, for example, apoprotein A1 or hyaluronic acid. So before hepatic resection, we can detect this serum marker to identify the post-resectional failure. This kind of project is still ongoing because of molecular biology technique enhancement. This is a treatment algorithm. So I've talked a lot about liver function test, but not that many is applied to the algorithm of the hepatectomy. Usually the symptoms in bilirubin and indocyanine 15, and then sometimes child classification or Vajik test, and the volumetry is used, and sometimes just child classification and ICR 15. And then this ascites bilirubin and indocyanine 15 is the major parameters for this hepatectomy. This is very simple and very nice, I think. The normal liver, the lab volume is the only thing is important. And then when the cirrhotic liver, the portal is child classification and indocyanine green is the only test is available for this kind of a patient. Future perspectives. So I think that we don't have any single liver function test to detect the post-resectional liver failure. So we have to think every single test is important. And nowadays, so many growth factors are identified, and then still so many omics technology, for example, genomics and proteomics and metabolomics is evolving, and so we can make a new, brand new liver function test because of these cutting-edge technologies. So I'm going to say, by saying in talk, this is usually the liver function test. We have to have a multiple liver function test to detect the first resection liver failure, usually indocyanine green and mebrafenib scintigraphy is important. And then, as you know, the volumetry is one of the most important things in terms of liver transplantation and post-resection liver failure. And then I hope later this kind of molecular technology can develop a brand new single, hepatocyte function test to evaluate the post-resection liver failure. Thank you very much.